The right hingibolabial sulcus is exposed using two falabella retractors. An anteriorly curved J-shaped incision is placed. A superiosteal pocket is created, and a malleus brain retractor blade is introduced to displace the periosteum laterally. Under endoscopic vision with a 0° 40mm lens, the superiosteal pocket is further elevated in a posterior superior direction using a free suction elevator. Simultaneously, the blade of the malleus retractor is further introduced by the assistant. The concave surface of this part of the posterior wall of the maxilla is followed beneath the zygoma. Cottonized soak with 1 and 1000 epinephrine are very useful in maintaining a clean field. According to the vertical height of the posterior wall of the maxilla, changing to a wider blade of the retractor increases the working space of the corridor. This is done sequentially, leaving the suctional elevator as a guide, and the new blade is introduced medial to it. Usually the 3/4 inch blade is the wider blade possible. As dissection approaches the maxillary tuberosity, the posterior wall becomes convex before reaching the pterygomaxillary fissure, and superiosteal dissection becomes difficult, so opening the periosteum in a vertical fashion as close to the posterior wall as possible exposes the contents of the infratemporal fossa. Inside the infratemporal fossa, adipose tissue is laterally dissected and maintained in position with the use of cottonoids held at the tip of the retractor. Further dissection of the adipose tissue exposes the lateral pterygoid muscle. Preoperative imaging in this case show a superficial maxillary artery in relation to the superior belly of the lateral pterygoid muscle, so once the muscle is identified, the artery is found anterior to it. Once identified, the main trunk of the maxillary artery is dissected using a middle meatus seeker and controlled with bipolar dithermy. After complete hemostasis is achieved, the retractor blades are pulled out of the surgical field, which automatically collapses. No need for packing is required, and the oral incision is closed with simple bicral sutures.